Hi there, I'm Dr. Evan Osar, developer of the Integrative Movement System. Welcome to this edition of the Integrative Movement Insider. In our last series, we covered 4 videos around the best core exercises for low back pain. We looked at some assessment, or one assessment, and we looked at some corrective exercise as well as integrative patterns for integrating the concepts from corrective exercise into the fundamental movement patterns. In this follow-up video series, we're going to look at the Psoas and talk about the syndromes and the solutions. So when we talk about the Psoas, we have many misconceptions, or we've been taught many misconceptions about the Psoas. So before we get into the exercises to help improve the Psoas, we need to talk about the biggest myth surrounding the Psoas. And one of the biggest myths around the Psoas has to do with the anterior pelvic tilt and the Psoas's contribution to the anterior pelvic tilt. So before we talk about why that's actually a myth, let's look at the origin and insertion, or the attachment points of the Psoas. The Psoas comes off T11, T12, and all the lumbar vertebrae. It fascially blends into the diaphragm as well. So again, it's coming off the front of the vertebrae, front of the spine, from T11, T12, L1 through L5 vertebral levels. Now, some people don't have a Psoas minor, and that's okay, because when the Psoas minor is not present, the Psoas major gives off fascial slips into T11 and T12. So functionally, most people have an attachment to T11 and T12. So again, it fascially blends from the diaphragm and the anterior vertebrae from T11 to T12 through L1 through L5. Now the Psoas crosses the pelvis and inserts into the lesser trochanter of the femur. But that's not the only place it attaches to distally or away from the spine. It also fascially blends into the pelvic floor. So it has fascial connections into the pelvic floor, and it also has fascial connections to the front of the pelvis. So now as we look at the attachments, both the bony attachments as well as the fascial attachments of the Psoas into the spine, the diaphragm, pelvic floor, and into the femur, we can see that there's no possible way that the Psoas can contribute to an anterior pelvic tilt. It does not attach anywhere on the pelvis where it can contribute to an anterior pelvic tilt. If anything, the Psoas contributes to posterior pelvic tilting, not anterior pelvic tilting. So that's the biggest myth surrounding the Psoas. Now, what's the best exercises for the Psoas? Because unfortunately, another myth, and we will not get into it in this video, but another myth around the Psoas is that it's tight and overactive. And unfortunately, that's not true either. I test Psoas in almost every low back pain patient, and every single patient, or virtually every single patient, the Psoas tests weak and inhibited. And when I look at the length of the Psoas, it's not short and tight. The other hip flexors, the more superficial hip flexors, the ones that are coming off, the ASIS, the AIIS, muscles like the sartorius, rectus femoris, TFL that comes off the lateral pelvis, they are short and tight. However, the Psoas is often and most frequently over-lengthened in clients that have low back issues and hip issues. So what are the best exercises that we can use to develop the Psoas and its role? So what does the Psoas do so we know what exercises are the best? Well, based on the attachment points of the Psoas through the lower thorax, the lumbar spine, into the pelvic floor, into the pelvis, and into the hip, it has 2 primary functions. And here's one more myth: it's not hip flexion. The Psoas's primary role is to stabilize that lumbar spine, to stabilize that pelvis, to stabilize the pelvic floor, and to stabilize the femoral head within the acetabulum. It actually is a very inefficient hip flexor. Yes, it can do it weakly, however, it's not its primary function. So the primary function of our Psoas is to stabilize our lumbar spine, to stabilize that thoracolumbar junction, to stabilize the pelvis, and to stabilize that femoral head within the acetabulum, so the rest of the muscles around our trunk, spine, pelvis, and hip can do their job. So what's the best exercise? We'll go into that in the next video. What we want to look at are the best practices. How do we use all that great collective information from the rehab world, from the training and conditioning world, from the performance industries, and teach our clients how to better improve their psoas function? Well, there's three key principles, and these form the principles of the integrative movement system and form the principles that we work and use with our own clients and patients in our clinic. And these we refer to as the foundational ABCs. We must teach our clients how to properly align their thoraco-pelvic cylinder. So get the rib cage stacked over top of their pelvis, maintain optimal alignment of that lumbar lordosis and that anterior pelvic tilt. The anterior pelvic tilt, slight anterior pelvic tilt, is the neutral position of the pelvis. The psoas helps control excessive anterior pelvic tilt, and it also helps maintain that position of both the lumbar spine as well as the pelvis. We must teach our clients how to breathe. Recall, as I said, the psoas fascially blends up into the diaphragm. So therefore, when we have optimal alignment and then we're using our diaphragm appropriately, the psoas helps anchor that lumbar spine and thoracolumbar junction to allow the diaphragm to do what it needs to do. So to allow the diaphragm to move into inspiration and expiration. Psoas facilitates optimal diaphragm function. Diaphragm facilitates optimal psoas function. Finally, we must teach the psoas to control the spine, control the pelvis, control the femoral head within the acetabulum. Foundational ABCs. We're going to go into that in the next video of this series. Remember, psoas, biggest myth, it's not a muscle that contributes to the anterior pelvic tilt, and it's not even a muscle that really contributes to hip flexion. It contributes to hip flexion by maintaining that femoral head within the acetabulum. So we're going to look at next video, the best exercises to train the function of stabilization of the lumbar spine, pelvis, and then of the hip complex as well. This is Dr. Evan Osar with IMI. We'll catch you in part 2 of this video series. Take care.